dear patients and caregivers. It's a great pleasure for me to be a part of the Myeloma Crown Roundtable today. So I was asked to tell you something about our clinical trials and also to give you some impression about the EHA meeting that is unfortunately this year completely virtual. So I'm based in Würzburg, which is in the southern part of Germany, and actually Craig Broadside knows this place extremely well, and we had several nice meetings in Würzburg and both enjoyed not only the food but also the great white wine that we can offer in Germany, in Würzburg especially. And also Jennifer was here once, and we also had a patient day in Würzburg with Jennifer. So our study group is really focusing on 4 questions at the moment. One question is, and I think this is a very important topic for every patient, is what is the significance of achieving a minimal residual disease-free state in myeloma? And so we have a study which was completed about 3 years ago. And here we used a triple agent induction, so Velcade, Revlimid, dexamethasone, transplantation, and we decided according to the quality of response whether we would do a second transplant. So one of the questions we try to answer in this study is a patient who has a good response after the first transplant really benefiting from a second transplant? And we also look into the role of MRD negativity as a very important predictive factor for progression-free survival and overall survival. And we are just doing another clinical trial, which again, we want to include about 600 patients, and Austrian and German centers are participating. And here we are really doing a risk-adapted and also a response-adapted strategy. And here we now use, and this is probably the modern strategy of treating a patient with multiple myeloma, is to use a combination, including a monoclonal antibody. And in this trial, we use carfilzomib, Revlimid, dexamethasone, and add in elotuzumab and see whether the addition of this monoclonal antibody is improving the quality of response and also progression-free and overall survival. Other study groups worldwide are using VRD plus elotuzumab or VRD plus isatuximab or VRD plus daratumumab. So you can add different monoclonal antibodies, either targeting SLAMF7 or CD38. And the general impression is adding in an antibody to the conventional induction treatment improves at least the response rate. And in some trials, it has been shown that the addition of the monoclonal antibody in the induction treatment also improves progression-free survival. Also for the non-transplant eligible patient now, addition of antibodies is becoming the standard of treatment already for the induction therapy. So where is the future going? And the future is clearly trying to use MRD as an endpoint. So in the next large German trial, and actually in this trial, probably we have a combination of the 2 German study groups, we will again study a 3-drug combination with a monoclonal antibody, a transplant, and a consolidation with this quadruple strategy. But, and that's new, our impression is that this is very good treatment for standard risk patients, but unfortunately patients that have high risk cytogenetics, ISS stage 3, that these patients are probably not still having a limited progression-free survival. And our feeling is that we have to add things, add treatments to improve the outcome of these patients. So we are trying to use now for this frontline strategy, CAR T cells and or bispecific antibodies in the high-risk situation, and also in patients who are still MRD positive after prolonged induction, transplantation, consolidation, and double maintenance for 1 year. So we clearly try to get especially more patients in the MRD negative state that have high risk features. And what are the strategies we can use here? I already mentioned CAR T cells and I mentioned bispecific antibodies. So what are we currently exploring? So we had the chance together with our French colleagues to test the first bispecific antibody, AMG 420, which is a classical BiTE molecule, so a very small bispecific antibody targeting BCMA on the myeloma cell and CD3 on the T cell, and thereby kind of redirecting T cells that are, for example, specific for the influenza virus. They get redirected to become specific for myeloma cells and kill myeloma cells. And we've been using these bispecific antibodies, and at the highest dose level, even in quite heavily pretreated patients, we had 50% complete responses and about 80% or more than 80% overall response rate. And we have now patients that are more than 1 year after this treatment still in ongoing complete remission. So even in heavily pretreated patients, these bispecific constructs are highly effective. And Dr. Nahi will later on also discuss teclistamab, which is another bispecific antibody also targeting BCMA, and there is another one from BMS Celgene, CC93269, another bispecific antibody targeting BCMA, and there are further BCMA targeting bispecific antibodies from Pfizer and Regeneron. So a huge portfolio of bispecific antibodies targeting BCMA is now in late clinical development, and further bispecific antibodies targeting other targets on myeloma cells are also in early clinical development. So why is it good to have more than one target for a bispecific antibody or a CAR T cells? We know, and we had experience, that some of these myeloma cells actually reduce the BCMA expression, and there has been one case at our department where we observed a complete loss of BCMA, and therefore it's always good to have other targets to redirect T cells, either by CAR T cells or bispecific antibodies, to the myeloma cell. And one development where we really also got a very kind support from the myeloma crowd, and Jennifer already showed this or pointed this out, is that we got some support for the development of a CAR T cell which is not targeting BCMA, but SLAMF7. And the beauty of this strategy is that we are targeting another target, not BCMA, which allows us also to treat patients that have failed BCMA targeting redirection strategies. But this is also a construct which uses non-viral transduction and a specific ratio between CD4 and CD8 T cells, which allows a very rapid production of these CAR T cells. Because normally it can take up to 6-8 weeks until these CAR T cells are produced, which means that we have to bridge the patient between the leukapheresis, when the cells are taken from the patients, to generate the CAR T cells until the CAR T cells are reinfused. And this time is often critical. And if a patient is rapidly progressing, or if the renal function is deteriorating, it's sometimes even impossible to treat the patient with the CAR T cells. that have been generated. So to reduce the time of production is very important, and that's an important strategy that we are following up in this Caramba trial. And again, thanks to Jennifer and the group for their kind support for this. And I can tell you that we're just starting to treat the first patient in the Caramba trial. In addition, what we are also working on is to improve the strategy of these bispecific antibodies. So one of the problems of CAR T cells and bispecific antibodies is that there is quite an intensive stimulation of T cells, and that these T cells secrete certain cytokines. And these cytokines can actually induce the so-called cytokine release syndrome or some neurotoxicity, which can be quite traumatic in some patients. Fortunately, in myeloma patients, very bad, very severe CRS or neurotoxicity hasn't really seen in a lot of patients, in contrast, for example, to lymphoma patients, where we see quite severe cytokine release syndrome and neurotoxicity. But still, it would be nice to completely eliminate this cytokine release syndrome and neurotoxicity. And one of the strategies that we are following up here are to generate so-called hemibodies or trispecific antibodies, and they target two antigens that are co-expressed on the myeloma cells. And by this, we hope to avoid unspecific stimulation of T cells and thereby to completely eliminate cytokine release syndrome and neurotoxicity. And we are now in the late preclinical development of the trispecific antibody that is co-targeting SLAMF7 and CD38. And another issue that I could address is the further development of CAR T cells. And you will later on hear from Dr. Nye and from Professor Moreau that there was quite interesting data reported at the European Hematology Association on especially the ID cell and the CAR-T2 product. So two CAR T cells, both targeting BCMA, that are quite advanced in the clinical development. The CAR-T2 trial showed a very high response rate in very heavily pretreated patients, so 100% overall response rate, but the follow-up is still short, so we have to see how these very high response rates are actually being transferred in a rather long, hopefully long progression-free survival. From the ID cell trial, and Philippe Moreau is going to show you the data, we know that again, heavily pretreated patients, very high response rate, more than 80% in heavily pretreated patients, that the progression-free survival is around 12 months in the highest dose level. And the question is, of course, we always hope that we would cure a patient with myeloma with CAR T cells. Why is the disease in about 50% of patients coming back during the first year after transplantation? And one of the factors that might play a major role here is that the persistence of the CAR T cells seems to be limited. So for some reason, after 1 year, in most of the patients, even using sensitive technologies, you don't find the circulating CAR T cells anymore. So this is one issue. Another issue is that probably, and in some patients that has been observed, the target antigen, so the target for the CAR T cells, is lost on the myeloma cell. So the question is, can we upregulate this target, or what we do in the Caramba trial, target another antigen that is still present on the myeloma cell when BCMA is downregulated or completely lost. And to target these two issues, so lack of persistence and lack of the target antigen on the myeloma cell, there are two strategies that are currently used. One is, and the data were actually presented at the ESCO meeting, were about the OVA cell. That's another CAR T-cell product. And the advantage of this one is that the binding domain of the CAR T-cell to the BCMA molecule on the myeloma cell is humanized. And one knows that if you use structures that are not completely humanized, that then there can be an immune response mediated in the patient. And that is going to reject the infused CAR T cells. So to humanize the BCMA binding domain reduces the immunogenicity of the CAR T cell and maybe prolongs the persistence of the CAR T cells and maybe increases the efficacy. So this is one strategy. Another strategy is the so-called BB21217 product. Here, they try to generate a CAR T cell population that has a specific renewal capacity. So these cells are more immature when compared to other CAR T cells products, and that allows them to longer persist in the patient. And the first data that were shown from this trial seems to indicate that this strategy actually allows to a longer persistence of the CAR T cells, and also in low dosages already a higher response rate when compared to a CAR T cell product that contains more mature T cells. And finally, a strategy that also I found extremely attractive is the so-called gamma secretase inhibitor. So this is kind of adding a substance which increases the expression of the target molecule on the myeloma cell by 20-fold, and thereby also increases the efficacy of the CAR T cells.